Hello, everyone. Welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, a patient-driven advocacy organization that operates in the United States and Europe, focused on advancing liver health for everyone. I have the honor of being your host for GLI Live. Thank you for joining us today. I have a very timely guest that I am excited to introduce you to, Dr. Tamar Taddei, who is chair of the AASLD Public Policy Committee, which is an incredible force for good for liver health policy in the United States and increasingly beyond, an important partner to the Global Liver Institute. And Dr. Taddei is Associate Professor of Medicine, Digestive Diseases, Director, Regional Liver Cancer Program at the Southern New England VA, and Associate Program Director from Yale MD PhD program. As someone born and raised in Connecticut, I'm very happy to invite someone from the Yale medical community. So, Dr. Taddei, welcome.
Thank you. Thanks so much for having me. I am really pleased to be here today to represent the Public Policy Committee. As you know, we rotate, so I'm chair for one more year, but I do have the perspective of having sat on this committee for some years now, and it's a pleasure to tell you about what we do.
I think that's fantastic. You know, as I have been working in policy for more than a quarter century, first starting with working for UNOS as a patient affairs specialist and one half of our government affairs team. I have seen the growth and the force and the effectiveness of AASLD in public policy, and have accompanied you on Hill days, and that partnership between patients and physicians, between patient advocacy organizations and medical society is so important. So I really do appreciate you being here today, but also just being with us every day.
Thank you. Likewise.
But I had an interesting, question, because I know a little bit about your background that I'd love to share with our audience. In addition to medicine, what brought you to policy issues?
So my undergraduate interest was in policy and diplomacy. So I'm a Georgetown alum. I went to the School of Foreign Service there with sort of grandiose ideas of being a diplomat, and was very interested in policy, and particularly policy where it relates to the interface between the developed world and the underdeveloped world, or as we called it back then, and sort of the importance of giving a voice to those who may not have a voice. So I studied very odd things like land disputes in Latin America and their history. And so I actually, my interest in medicine happened much later. I took a very meandering route, but along the way, I actually figured out in my last year of college that I should probably do some science. And I sort of went back and did a lot of my pre-med coursework at night while managing a sister who had suffered a traumatic brain injury. And so I actually became an advocate for people with traumatic brain injury. And that advocacy piece took me all the way up to the state legislature to really redo the way we manage Medicaid waivers for patients with TBI, at least in the state of Maryland, where I was residing at the time. So I sort of had a very strong policy and advocacy background, went into medicine, fell in love with liver disease and just the whole sort of pathobiology of the liver. It's a phenomenal organ, best organ in the human body. And so I've been able to kind of dovetail my interests over time, which has been really a gift. I mean, most people sort of look at their career as a very kind of focused thing, and I've actually been able to combine a couple loves, which has been wonderful.
That is fantastic. The liver is a many-splendored thing.
It is.
I rewatched Eat, Pray, Love the other day, and I hadn't remembered the line when she's in Bali and she's asked to smile with your liver. And I was like, we're gonna have to sort of capture that. But so thank you for choosing hepatology. As many people know, but for our audience, you have to go through internal medicine training, gastroenterological training, and then hepatology training. So there's a lot of dedication that goes into getting to the position that you are in, and we thank you for it. So tell us how the AASLD Public Policy Committee works. What do you all do?
So we actually decide upon a public policy agenda annually, which we work with the governing board to make sure that it's representative of all of our interests and where we really think we would have impact in terms of either designing or supporting policy. We are composed of lots of different types of folks. So the majority of us are hepatologists, but we have surgeons and trainees also on the committee. We have patient advocates on the committee, which is a new development as of about a year and a half now, which has been phenomenal. And so we really want to capture the voice of the society, but also the voice of patients with liver disease, and to be able to advocate in every arena where we would have impact. And so this is really a constant flow between the Public Policy Committee and the Governing Board. And the Governing Board actually sends a liaison to our committee so that the Governing Board is kept abreast of everything the Policy Committee is doing. For a societal committee, we meet quite frequently. We meet once a month. In sort of off meetings during the month, we're usually sent policy to review and comment upon. And then my job as the chair of the committee is to essentially pull those comments together and make sure that we're communicating with the governing board and with our government relations firm.
That's fantastic. That you're meeting monthly. Certainly, policy is moving very quickly these days.
Yes.
So, you stated that you already had a type of diversity within the committee with different types of practitioners, but also practitioners who are focused on different types of liver diseases is an additional that's been in the committee. But how has the dynamic changed, if it has, by adding patient community members to the committee?
In a couple ways, actually more than a couple. I would say first and foremost, just the passion that they bring to the table. So the discussion is more intense, more goal-directed, more sort of framed from not only the perspective of the society, but of our constituents, not just providers, but patients. I would say that, the advocates actually have a lot of connections within their own advocacy groups, but also among advocacy groups, and they've made us aware of things that perhaps we didn't know about yet. So it's almost as if there's a sort of vanguard of patient advocacy that keeps us in the loop just as much as we're trying to keep ourselves in the loop, and we're looking to our government relations firm to help us with that as well. So I think it adds a layer of information. It certainly adds passion. I think it elevates the conversation. And I really, when I say that, I do a lot of teaching, most of us in medicine do, and there's nothing like having a student with you, because to be honest with you, you are on your best behavior. And so I think the dynamic of having an advocate in the room really makes the conversation stay on task. We're not going to digress. We're not going to talk about whatever, professional things bother us, because we really have a task at hand. And I think the patient advocates keep us really focused and really elevate not just the conversation, but the direction, the focus, our goals, our agenda. So I have to say, I have really, really enjoyed it.
Well, we certainly appreciate that receptivity. Having had the privilege of being invited in to help AASLD implement the strategic, the part of your strategic plan around patient engagement, and being asked, what are the first committees? What are those really essential committees that we feel that patients could most contribute to positively? Of course, my answer was all of them, just for the For those, nobody who knows me will be surprised by that. But public policy was certainly one of the ones that, across the patient community representatives, we understood to be the most important, for all of the research and the innovation. If it doesn't ultimately get to people, as it's reimbursed and adopted and integrated into health systems and supported by strong public policy, it really isn't. It's not fully realized, and so we really do appreciate your receptivity to the community members on the committee. My motto is always patients are very practical, and I think that's what you're seeing. We are really grounded in, are there solutions for people who are in need and struggling to solve problems today. So that sense of urgency is something that it's.
Well, and I mean, as much as I would pray that nobody ever has to approach it from that sense of urgency, I don't think any of us are sort of deluded into thinking that one day we won't be on the other side, right? So I think, eventually we are all patients, and we really need to bring that dialogue in, I think, on every level of medicine, healthcare delivery, and research. Oftentimes I think doctors will go into research not thinking, is this question even important to the patient? Mm-hmm. Or is there some component of this research that would be important to the patient? So I think now more and more we're seeing the patient voice in research, in policy, in our societies. And I think the ability of patients to stand up and say, wait a second, we are not some other. Like, this is what concerns us and our welfare and our longevity and our children. And, that conversation and the accountability that it brings to bear is really important. And it's not, when I come to a committee, okay, I'm a doctor, sure, I did the training. You're a lawyer, you did all that training. It's a lot of training, but ultimately we are people who suffer, and we want to make life better for those. And we have a unique skill set, but we all have to bring our skill sets to bear and look at this as what are the solutions to the problems at hand. And so I think in a way, the public policy really, the committee really does approach policymaking in that way, which I think has been very refreshing to me. And we also do examine our skill sets, who's got, expertise in X, Y, or Z, and who's best to answer these questions on this particular policy. But I do think that we have to continue to break down the silos between patients and doctors. We're on the same side,
We absolutely are. And one of the most effective tactics you often use on the Hill is for me as the patient to take on the physician issues, because it is important to have hepatologists available to be able to treat me. So your practice issues, your reimbursement issues are important to me as well, to make sure that you're there when I need you. I remember being hospitalized, and I have both IBD and liver transplant and a variety of things. And so when I'm an inpatient, the GI service comes to see me, the transplant or hepatology service comes to see me, often many others do as well. But I hadn't realized, this was several years ago, when someone mentioned they had to sort of flip a coin as to who got paid. Because in several instances, both GI and hepatology, because right, hepatology often sits under GI, could not both be reimbursed for seeing me, for giving me counsel, even though they were bringing very different sets of expertise, very different and uniquely valuable care to me. And so those are the types of problems that, when elevated and as set in an advocacy agenda, we can bring forward jointly. But it's not often raised to the patient attention, so that we can put it on our advocacy agendas as well as your own. So we have aligned very closely, I think more closely than ever, in 2020 in the age of COVID. And so tell us about the progress that we've made, or the successes of 2020.
2020 has been a trying year. I think we've all pivoted in one way or another. I think the AASLD has done a phenomenal job in pivoting, both to address policy issues with COVID, but also to address, how to keep people informed, educated, moving the science forward. So we've done. There is a COVID task force that was set up during COVID, and they've really taken a sort of multi-pronged approach to educating hepatologists and all the allied providers, educating patients, making sure that we advocate for CDC to consider patients with liver disease as a group that's at particular risk. So all of this has been quite a lot of fast and furious work. As you know, you can't predict these things, and so we had to pivot quickly, and I've been really amazed at the leadership of the society. I have to say that I think now that we have, a vaccine, it's very important to also be mindful of just the stressors on the whole system. And so I think we've taken a very mindful approach to when we think we need to really have a voice and when we ought to see how things play out. So I think vaccine delivery is a huge undertaking, one that has never been undertaken to this degree. And so we are all incredibly supportive of all of the efforts to get the vaccine out. But I think we also have to be tempered in making sure that we don't detract from that main mission, right? Because as you can imagine, so many different groups probably, really feel that they should be first in line for a vaccine. Mm-hmm. So I think, I think that's taken some thought. I think, it's always important to know when to speak, when to be silent, and when silence could be taken as tacit acceptance of the status quo. And I think the leadership of the AASLD, specifically under Dr. Bezeha, has been incredible in really understanding those cues. So as you know, in the middle of COVID, we also had a lot of other policies come to the fore, one of which was CMS and payments, and the whole new E&M coding and whatnot. That was quite a bit to digest and respond to. In the same year, the NIDDK asked for suggestions on what the new, grant structures and RFAs ought to be. Mm-hmm. So we had to sort of compile the society's sort of wishes from a broad group of constituents. And I should say the way the society is structured with special interest groups, we're really able to canvass everybody fairly quickly. And so all of the SIG chairs can canvass their SIG constituents, get, information and opinion, push it right up, and then we can distill it. So that's been really nice to see happening, both for routine policy things we'd have to address, like the NIDDK and CMS, but also for things like COVID. Where do we want to speak? What do we think is a top priority? What do patients need to hear? How do we educate our providers? So I would say that we've been on high alert, I think, as everybody has. But we've also tried to be very mindful of what a difficult time this is for policymakers, and not just COVID, but all of the unrest that's been going on in our country. I think we need to treat each other with kindness and respect. And I think that's really been that whole idea that you want to instill a culture where people can be heard and can have their opinions dissent with collegiality is one that the AASLD, that culture pervades that society, which is fantastic.
I think that's fantastic, and certainly your diplomacy skills have come in handy as you navigate these many issues over the past few months, and also new relationships and new constituencies. I have observed greater collaborations across all of the gastroenterology groups and common statements, and those have been very well received, and they've pulled together so quickly that it's been really amazing and helpful to the patients who were looking for a sense of direction and confidence in the system for both COVID and non-COVID care, for access to transplants or liver cancer screening, and recognition of the fact that our diseases did not stop progressing.
Right.
Care did not stop just because there was another pandemic on top of that. So we touched on vaccination, which is sort of the topic du jour, and I have to admit I was very excited this morning. I've been sort of stalking my chart every morning to see if my husband, who is in a different age group, would become available. And we've never navigated a patient portal faster and he's actually on his way right now to get his vaccine. But helping CDC and others prioritize liver patients and the different types of liver patients, and understand where we may be more or less vulnerable to contracting COVID, more or less vulnerable to more severe effects of COVID because of the constellation of medications or immunosuppressants that several of us are on, depending on disease type. And now with the vaccine, with the limited data that is in these trials, both because of the composition of the trials and the short time period in which they were developed, it's just a matter of having very limited data for them. GLI is currently undergoing a request from all of the transplant centers to ask what have the communications been, so that we can help patients navigate and personalize their own choices for that, because we know the opinions are still diverse while we await more data. I'm happy to announce that when I am fortunate enough to get a vaccine or be offered one, I will take it and participate in any trial for response of transplant recipients that stood up. I think that is part of our responsibility, as leaders in this field, to advance the science and create that data.
Absolutely. I mean, we really need long-term follow-up data. And so I would say that whoever's offered a registry trial post-vaccination really should sign up. I mean, what's the harm in a few questionnaires here and there? I think it's very important. I think it's important. Really, we haven't seen the natural history of COVID-19 play out. I think one of the things that has been startling to me is the fact that we are trying to do science in a social media world where everything is out there. Misinformation, information, uncertainty, doubt, evidence, lack of evidence, right? And so, when we do the process of peer review, when we look at a study and we assess the validity of the study, its reproducibility, the techniques that were involved, we take time it takes time to do that. And I think that unfortunately, with just how quick it is to get information out there, no matter the quality of the information, I think unfortunately the vast majority of the population probably feels confused and really unsure of what to believe. And so I think that people have to understand that never before has a disease run its natural history in real time, right? It's quite incredible to me. And I think that we're going to continue to learn about COVID. We're going to learn as time goes on. It's quite possible that some of our preconceived notions may be notions and may play out differently. So I think people really need to stay tuned and just understand that the more they can contribute primary source data, their own data, to that science, the better. Because, we're still in the infancy of understanding this virus.
So you were so articulate about what sort of the average person reading information on social media needs to know and look for. But for our policymakers, what do they need to understand about liver patients and liver health to support good policy moving forward?
So I think for our policymakers, we need to explain to them that the liver is an incredibly important organ for which there is no replacement apart from transplant. And that about 100 million Americans are at very high risk for progression of liver disease from fatty liver, also another disease whose natural history we're still learning, right? So I think that policymakers need to understand that prevention is key. So where you can prevent, you should prevent. And that comes with access to food, access to education, access to a culture and a way of life that is centered around wellness and longevity. And so I think that you're seeing some of these things happen, but it's happening more, I think, at a grassroots level than at a policy level. Certainly some of the policy changes around dietary recommendations have been very well received and well received by the liver community because they create a more balanced diet and one that's less likely to result in obesity. But I would say, policymakers are always interested in, the sort of what's the greatest population that could be affected by my policy, right? Mm-hmm. And so I think if we're talking about liver disease, NAFLD really kind of goes to the top of the list. However, I think it's also very important to understand that a lot of scientific advances have been made on the observation of outliers. Mm-hmm. And who are outliers? Outliers are people who have rare diseases or diseases that affect a very small segment of the population, but their study sheds light on canonical processes in disease, okay? So for example, autoimmune hepatitis, mm-hmm. relatively rare among, other liver diseases, mm-hmm. but the study of inflammation, which is a canonical process, right, uncovers so many potential treatments, targets, et cetera, for not just autoimmune liver disease, but all types of autoimmune disease. Mm-hmm. And autoimmune disease is not a trivial matter. So, I think people need to understand that we have a lot going on in our environments. We have a lot of exposures where we've gotten very good at understanding sort of the genome. We're working on the microbiome, but we haven't even tapped the surface of the exposome. What is it that a lifetime of exposure to X may do to the way your body handles those exposures, right? And so a lot of the thought is that perhaps autoimmune disease may be aberrant handling of things you're exposed to, during your life. So I would say that policymakers should really think about advancing science that can use technology and population, the understanding of populations, even very rare populations, to unlock clues that would have a huge ramification for much larger populations. Now that is, you have to do some education there. I don't think policymakers really would make that leap without some discussion, but that leap is really important. And I think that AASLD understands that it is important to really not just talk about fatty liver, which of course is it's sort of the no-brainer, right, when it comes to policy, but to really think about all of our constituents, people with autoimmune and other rare liver diseases, people with sort of what happens at the end of the line, what happens when you have end-stage liver disease, perhaps liver cancer. What are we doing to improve quality of life, to improve the care of patients who are facing complex, highly specialized type care required for illnesses like that. So there's a spectrum in terms of, where do you want to have action? But I think that action is required at all points along the spectrum, with the eventual hope that if we work hard at the front, at that prevention end, maybe we won't see all of this down the line, but those patients still need to be cared for, still need to see advances, still need to see treatments brought to the table that could prolong their life. So that's sort of the way I look at it. I think policy can be looked at on a continuum, but you shouldn't lose track of the smaller arguments that actually may have much wider ramifications, just, you know, in defense of that larger argument for the larger population, if that makes sense.
It absolutely does. Certainly, as an autoimmune patient, I am appreciate that those of us with the rare liver diseases are not left out. I appreciate that in the PCORI authorization, rare diseases were given a specific mention and a mandate for research in that area. We've launched our Pediatric and Rare Liver Disease Council, and it is as robust or vibrant as our liver cancer and NASH councils, coming together so quickly because the urgency and the focus of the multiple smaller organizations and advocates who've been so passionate and working often in silos or alone for so long on these individual rare diseases, didn't have a home previously to come together and say, what things do we have in common? Next month we'll be focusing on rare diseases, rare liver diseases, and there are several things that could advance all rare liver disease patients or shine a spotlight and focus education so that pediatricians are more able to diagnose a rare liver disease earlier when they can, or it doesn't fall out of the constellation of diagnoses in primary care or others. And so with that diagnosis in hand, initially there's a greater likelihood that we can match to the treatments that are starting to evolve. But I really support your look at policy across a large framework. People think that liver issues are so small, and you've really shown how broad they are and how liver health is public health, is population health, because everyone has a liver, and so they're at risk at some type of liver disease, and we need to think about it that way, and so be involved and integrated into legislation and other policies around prevention, nutrition. I know that NIH is rethinking and repositioning nutrition within NIH. I think that was certainly important, not just to the fatty liver disease and NASH constituents, but you're right, to autoimmune patients. Our nutritional status, our microbiome are all affected by that. So research policy as well, regulatory policy, so that FDA understands our issues and can work effectively across the divisions to approve appropriate liver therapies, and then working with health systems and making sure that clinics and hospitals around the country have the resources that they need to deliver care to the diversity of liver patients. I'm privileged to live in an area where there are, many hepatologists and gastroenterologists, but there are, rural areas and other areas where there are very few. So how do we connect them to hepatologists through telehealth or through things like Project Echo, and how policy solutions that support the delivery of healthcare to even the most complex. And then in transplantation, we have talked about organ procurement, accountability, and ways to just improve donation and appropriate use of organs. And then unfortunately, if all of those fails, we end up with liver cancer. And so how can liver cancer screening and the new vast array of treatments be made available to liver cancer patients, and liver cancer have the same great news I saw in the paper today about other cancers declining. How can we have those same results for our patients that we do for other cancer patients? So it looks like we'll be working together very closely for a long time to come. And I thank you for that partnership.
Well, it's a pleasure. Thank you for having me today.
Thank you. So, for all of our listeners and watchers, Dr. Taddei squeezed this in to a very tight schedule. So I just want to express my appreciation to you for making time for us, and then really just demonstrating with your time and dedication how important policy is and the partnership with patients. This video, for those of you who are not watching in real time, will be available on the Global Liver Institute website, our YouTube channel. You can find us on Facebook and Instagram. You can always email us. We'll send these resources, our COVID-19 resources, which link to the AASLD COVID-19 resources, and happy to answer any questions. We will be taking a break next week to celebrate the peaceful transition of power in the United States on Inauguration Day, and then we'll be back with you the week after. So until then, thank you, stay safe, stay connected. Bye-bye.